So now let's talk about Roux stasis. This is not very commonly seen. I personally have not seen this, but it is mentioned. So most of it is because of motility, disordered motility in the Roux limb, and instead of forward peristalsis, retrograde peristalsis happens. And again, this is rare, so you have to rule out other conditions. You have to rule out mechanical obstruction and gastroparesis before you go in. Again, physiology is that the motor complex, MMC complex, is disturbed. You are removing the duodenum from continuity of the food flow chain, and sometimes you might leave a very long Roux loop. So this might lead to another ectopic site of impulse generation, and your Roux loop might push food in the opposite direction. Again, so the options for these include: you can shorten the Roux limb, you can do a small surgery, reduce the size of the Roux limb and do a re-anastomosis. You can reconstruct with a free jejunal limb segment, so that sort of pushes it in the normal direction. You can change an anticolic to retrocolic, that you do if you can't find anything wrong and you don't know what to do. And you can convert a Billroth-2 into you can convert it to a Billroth-2. You can do an anastomosis and maintain continuity. So whatever way the food goes, it ultimately drains downwards. Newer proposed modality is where you do electric pacing. So here near the jejunal limb, you put electric stimulation so as to push the food in one direction, so as to reset the intestinal pacemaker. Again, this is something that we have read about. I have not tried, so my experience in this is very limited. Now, this gastroparesis is very commonly seen. A lot of people think that it is primarily due to the vagal nerve denervation, and sometimes the remnant stomach does not contract. But in some cases, it is always important to make sure that the GJ site, the gastrojejunostomy site, is done in a draining portion. Sometimes if it is not in a draining portion, it can be like a pseudogastroparesis, where it is actually not draining properly, and that results in a gastric outlet obstruction. Most of the management of gastroparesis is again medical. If it does not resolve, what we have done for 2 cases is we have gone ahead and done a total gastrectomy with a esophagojejunostomy. Alkaline gastric reflux. This is seen in a small fraction of the patients. Chronic exposure of the gastric remnant to all the biliopancreatic secretions, and this causes some amount of significant discomfort to the patient. Surgical management is mostly a Roux-en-Y reconstruction with a 45 to 60 centimeter Roux loop, not more than that, or you can put a isoperistaltic jejunal loop in between. Or the commonest, easiest shortcut is to do a bronze enteroenterostomy in the first place, so that there is no reflux. This, I think, will go to the management. Convert a loop into a Roux-en-Y if there is a esophageal reflux. Sometimes you need to resect the gastric conduit and do another anastomosis. So dumping syndrome, again, most of dumping syndromes are managed medically. You don't need to go in and operate these cases, but then again you make sure there is no narrowing. You can convert a GJ into a gastroduodenostomy, conversion to a Roux-en-Y, or you can do a reconstruction of the pylorus. That is still it's not very commonly done. When you come to stomal ulceration, here it is very important to rule out any malignancy. If there is malignancy, recurrence, then you go in and resect it. If there is stenosis, in a lot of cases, if with dilatation it does settle, you do not need to go back and do surgery. This is very rarely seen, but when it is seen, it is a major problem. Ideally, you have to go and do a segmental colectomy, resect a part of the stomach, which is a sleeve resection of the remnant stomach, or do a total gastrectomy. Recently, there is something called regenerative endoscopy that we are doing in AIG, where you take adipose tissue cells, derive stem cells from that, and try to inject it into a fistula. It is still in a very experimental stage, so probably not recommended, but it is one of the new modalities being tried out. So we have covered the known complications, but anything can go wrong in surgery. Murphy's law, always to be followed, but most of these are manageable. Sometimes they are not in your hands. So, it is very important to maintain an open mind. Each problem deserves its own targeted approach. To summarize my talk, I would say prompt recognition, early re-exploration is the key when needed. Late complications generally can be managed endoscopy, but if they are not settling down, then do not hesitate to do surgery. Most of the time tailored interventions are required. Nutrition is very important in managing these patients. Just because you can go and do a re-surgery, do not do it unless you have good nutritional, you maintain the patient's nutrition, otherwise they will never recover from the post-operative care. Always go through a multidisciplinary care. Interventional radiology and endoscopists are your best friends post-operative. And to summarize, early leak skill, if you do not intervene, late loops which delayed loops debilitate. Clinical judgment is always your best ally, and always remember reoperation is not a failure, delay is. Okay? Whenever you attempt any restoration or reconstruction, consider both anatomy and function also, not only anatomy. And long term follow up is very vital for all these patients. Thank you so much.